So I will take the view that yes, we should preferentially use vagus nerve stimulation early in patients with both seizures and depression. I thank my esteemed host for her supportive comments in advance. I think I am 3/4 of the way there. But let me give you a little bit of evidence to try to support this position. And in this, I guess one of the key words here in the question is early. Should we use it relatively early? And I'm going to argue yes. These are my conflicts of interest, none of which are terribly relevant to this. And in fact, it's all paid to Jefferson, not paid to me. So as was mentioned earlier, depression is a common comorbid condition in epilepsy. 1/4 to half of people with epilepsy experience depression. It's even higher in people with uncontrolled epilepsy. Perhaps as many as 3/4 have depression. And depression is associated with a poor quality of life on the quality of life surveys, so that's a little bit of an unfair statement, because if you look at studies that have been done about quality of life, the major determinant of quality of life is mood. And in studies across multiple disease entities, the Brecht depression inventory correlates very nicely with quality of life. People who are unhappy have low quality of life. People who are happy have good quality of life, irrespective of anything else. So when you treat mood, you improve quality of life. And that relates also to seizure frequency and seizure severity, and obviously side effects of drugs and comorbid conditions. So they also may share the similar neurobiological mechanisms. They may have similar anatomic substrates, that is depression and epilepsy, and both may have disruption of GABA and glutamatergic glutamate neurotransmission, and serotonin may be low in both. And both conditions are associated with stress. So it's reasonable to think that a drug that treats both, or a different type of treatment that treats both, may have efficacy in both. And then I would argue that what you want to do is be efficient. And why give two different treatments when one treatment is the same? So why not use a single therapy? Rather than giving an antidepressant and then an anti-epileptic, why not use something that is both antidepressant and anti-epileptic? And if one has used an anti-epileptic drug which has not been working in the past, and you're moving to the point of refractoriness where you're thinking about VNS, why not use VNS if the person has depression, rather than continuing to use joint therapy? And the big advantage, and really what I'll push, is that side effects. So, and Eleanor, you're absolutely right. It's almost impossible to read the slides on this screen. So what are the biomarkers of epilepsy-related depression? So we have a few biomarkers listed up here, and maybe I'll step away from this because I can see that screen a little bit more easily. So we have the 5-HT1A receptor. So this is the serotonin receptor, postsynaptic. You can demonstrate with PET and an autoradiography in animals that there are decreased numbers in depression associated with epilepsy. The presynaptic as well as the postsynaptic effect shows increased function, and then the hypothalamic pituitary adrenocortical axis also shows abnormalities both in epilepsy and depression with the dexamethasone suppression test. And then there's also evidence for inflammation with interleukin 1B, interleukin 6, C-reactive protein, S100B, tested by ELISA, and this is elevated in both. So we have common neurobiological mechanisms that I can demonstrate with data. So how should they be treated? Since VNS has demonstrated efficacy for treatment of drug-resistant seizures, we could consider that as well. It's well tolerated, and one of the nice things about VNS is that it lacks many of the side effects of anti-epileptic drugs. In fact, it lacks almost all of the side effects. It has its own category of side effects by and large. And I would argue too that it's cost effective. So for those of you who say, but VNS is much more expensive, I would say perhaps not, and I'll show some data. And again, it has demonstrated efficacy for treatment of depression. We saw a little bit of that. I'll show some more, but multiple studies demonstrate efficacy. And there is some support that it helps mood in people with epilepsy. Also, the converse is that when you're thinking about this, antidepressant drugs don't work especially well. They have some effect maybe, but it's dubious. And for patients with drug-resistant epilepsy who suffer from depression, I would say it's an effective means of treating both. And why not use it earlier rather than later and avoid exposing people to so much drug side effect? Now, there are a number of VNS systems available, and what I've got pictures here. What you can see on the left at the bottom is the latest Cyberonics device, which is the device that monitors heart rate and can stimulate with heart rate. The somewhat older device, still in many people and still available by and large, is there. However, Cyberonics tells me they charge the same for both, so I don't know why you would use the older device rather than newer ones. And then in Europe, you've got a couple of external vagus stimulators approved as well, which are not available in the US. So we have projections of the vagus nerve, and this sort of summarizes why, again, in addition to the mechanistic input that I said that makes a difference. So 80% of the fibers in the vagus nerve are afferent rather than efferent. The vagus nerve is sending fibers to the viscera in the chest and in the abdomen, but 80% of the fibers are actually afferent, and they're projecting up to the nucleus of tractus solitarius, and from there they're going to all those places that can affect mood, in addition to epilepsy. And it can affect hormonal, autonomic, and behavioral systems. So we've got projections to, as you can see, the nucleus of the stria terminalis, central nucleus of the amygdala, paraventricular nucleus of the hypothalamus, lateral hypothalamic area, central gray matter, lateral parabrachial nucleus, locus coeruleus, and then from there, via secondary projections, you're affecting frontal cortex, you're affecting cingulate, you're affecting the amygdala and insula, nucleus accumbens as well. So this is a system that's all linked in so you can positively affect mood, and these are secondary projection. And in addition to affecting mood, it's modulating cortical excitability. So this is the original response, and I showed one of the early papers from Professor Ben Menachem back when she was only 22 years old, not now when she's 39, approaching 40, sadly. Just the original data that VNS has some efficacy. It's not great, and I have to say, when I think about a highly efficacious method of treatment, it's not a cure by and large. It's a palliative treatment, but it's not a bad palliative treatment, and I think it avoids a lot of side effects of drug. So you can see a bit of benefit from high dose versus sham stimulation or semi-sham stimulation, very low dose. And the side effects, as were shown before, again, you don't get the unsteadiness, the dizziness, the depression, the trouble thinking, the clouding of awareness, the mood changes that you do with anti-epileptic drugs. You get more modest things that people by and large live with and it don't bother them. They have alteration of voice. So hoarseness is very common while the stimulator is on, and when it's not on, they're not hoarse. So for example, I have a patient who sings in her church choir. So what does she do? For the hour that she has choir, she tapes a magnet over her VNS. The device is temporarily off. She sings all she wants. Then she untapes the magnet, and she has therapy. Another patient of mine is a school teacher. He teaches in junior high school, so 12 and 13-year-old boys and girls who are perhaps the most challenging people to teach. So he has actually a lanyard that he wears, and he puts the magnet that's attached to like our badge, he just sticks it in his shirt pocket, which is over the device, and then his VNS is off when he's lecturing, and then he can pull it out to let it go on when he needs. So a lot of these side effects are really quite transient, not usually a problem, but it can be temporarily avoided. The vomiting and paresthesia, which is cited at 18%, I must say I have never seen that, never. Surgical infection rate is possible. These are brief, self-limited, and only once have we had to remove a VNS for a surgical site infection. So these side effects are well tolerated. So it's an easy thing. And then again, with Professor Ben Menachem, a very nice paper looking at retention rates now, and your people are much more likely to stay on VNS therapy than they are for other drugs. Now, this is not exactly a fair comparison because stopping a drug is a lot easier than stopping VNS, and once you've gone to the trouble of having it put in, you might as well leave it on. So I don't know if this is truly valid in that sense because since it doesn't bother people very much, there's no harm in leaving it on. But nonetheless, this supports my argument, although I take this paper with a grain of salt, even though it was published in a very good journal. And then as far as cost savings, there's a nice paper that was published in 2011 by Sandy Helmers, unfortunately the late Sandy Helmers, which showed that while there's significant cost early on, through time, VNS actually is cost effective and it saves money. So there's the initial cost of implanting it, but once you get out beyond 5 years, there's a significant cost saving. And this is just shown observationally that people cost less money. So it's more expensive this year. When you look at a longer period of time for a health system, it's actually a cost-effective treatment. And then for depression, again, this is a nice study published by George in British Biological Psychiatry, that VNS plus treatment as usual, so treatment with medicine for drug-resistant depression, that it's better. And what you see with treatment is a greater reduction in the, somehow I advanced it accidentally. Oh, I'm going in the wrong direction, I'm sorry. Yeah. That the drop in the hospital-related, hospital anxiety and depression score. I'm sorry, this is not the hospital one. This is, I can't read it. I can't see it on here. I can't see it in here. But whichever depression score this is, there was an improvement. And then, again, looking at this score, and this one is, I think, the Montgomery-Asberg score in this paper. Again, with remission rates, so response rate initially and remission rate after 3 months, and then 1 year, you get this sustained and progressive effect, so that VNS is not bad for depression. It's actually pretty good. And then also the other argument, and this is the argument I'll make for early use, the more drugs you give people for depression first, the lower the response rate to VNS. Now, there are two ways of looking at that, and Dr. Theodore, I'm sure, will criticize me, so I'll address this in advance, because you could argue that the more drugs somebody has had, the lower the response to anything afterwards. So that's an obvious second conclusion. But it was interesting that when you look at treatment, sort of response and remission, and response being an immediate and remission meaning a sustained response really at 1 year, that people hadn't done anything, there clearly is a beneficial effect. And, arguably, once somebody has failed 4 drugs, Bill, since you'll be saying it, versus 6, I'm not sure that there's a heck of a lot of difference. I suspect depression's a lot like epilepsy, where the people who have failed 4 are as resistant as the people who have failed 9. But this is an argument for employing VNS a bit earlier, that there's a little bit more of a response. And then the studies in epilepsy are somewhat limited and uncontrolled, so we can take it with a grain of salt, but again, just as improved quality of life has been observed, improvement in mood, and this one's with the Montgomery-Asberg scale as well, and a high dose and low dose in an incredibly small number of patients, nonetheless shows improvement. And there have been several other studies, and you showed one very nicely just before. So the other thing is, what is the alternative to VNS? Well, it's antidepressant medication, and how many in the room use antidepressants fairly frequently? I'll raise my hand, all of us do. How many of you are convinced they work really well? No hands went up. Well, one hand went halfway up. Okay, one hand went all the way up. I think occasionally it works well, but they're far from ideal, right? I mean, they don't, I mean, and the effects are relatively modest. There have been a number of studies, actually, and this is a paper that's not even in print yet, it's just online. I found it preparing for this talk. It just came out in Lancet recently, within the past month, by Cipriani and his colleagues, where they did a meta-analysis of 522 double-blind studies with over 100,000 patients. So it's actually a good paper to read for we who are neurologists in the room, in addition to psychiatrists, who were randomly assigned to drug or placebo. And they were able to find that when you lumped all these studies together, for whatever meta-analyses are worth, that they did find that drugs were somewhat more efficacious than placebo, but the effect sizes were modest. And then I'll show you, there are some drugs that appear to be better than others, but again, if we're going to believe it, escitalopram, which I think a lot of us use, mirtazapine, which is an older drug that not many of us use, was also quite good. Paroxetine also, but paroxetine has a lot of interactions with some of the older drugs. So if you're using levetiracetam, paroxetine is good. If you're using carbamazepine or some of the other inducers, paroxetine is a bigger problem. And then agomelatine and sertraline also is a much more effective drug. And then interesting inferior drugs are reboxetine, trazodone, and fluvoxamine. But again, the effect size is relatively modest. And again, with our patients with epilepsy, we're giving them drugs that have some antidepressant effects already. So how well these drugs work in addition to an antidepressant that we're prescribing for seizures. You give your patient oxcarbazepine, you give your patient lamotrigine, you give your patient valproate. It's not clear that in that circumstance we're buying very much more with drugs as opposed to VNS, which has a different mechanism. So this is the a graph from the Cipriani study, which again I would encourage you to look at online if you just search under PubMed Depression Lancet 2018. You'll find that it'll pop up right away. And you can see the list there, which again, my screen is unreadable there. But as I was saying, interestingly, the #1 drug is amitriptyline, okay, which also is #1 in side effects in my experience, but I tend to use nortriptyline, but amitriptyline, the good old ones, mirtazapine, another good old drug, okay, duloxetine, venlafaxine, okay, those are high ones. So this is odds ratio, and it goes from 2.13, most of these are 1.6 to 1.8, and then it goes down. But there is some efficacy there. On the other hand, just to show you, there are many studies in the literature, and this is a good study of sertraline in chronic kidney disease, a relatively recent study published in JAMA. The placebo group and the treatment group do the same. There are loads of negative studies for antidepressant drugs in the literature, and that's why some of these meta-analyses are needed. And one would argue when you need to do a meta-analysis to be convinced of results, you don't have a good drug. Because when I am treating people, it's not like I'm giving 5,000 people a drug and looking for a subtle improvement in depression. If you're depressed, I'm giving you that drug, I want you to be better. If I have to do a statistical analysis of a meta-analysis to figure out that the drug works, it's not very good. Okay, and then this is from that Lancet paper, again, and you'll notice I'm using reputable journals, JAMA and Lancet, right? Wish I had epilepsy in here too. In terms of acceptability, so dropout rates, and you'll notice the dropout rates are kind of dismal, that a lot of the drugs are below the line, and only 3 are really above the line significantly: escitalopram, fluoxetine, and agomelatine. So there are a lot of problems with these drugs. And then what are the adverse effects? Well, weight gain. And it's hard to find the incidence, but it is incredibly common. I mean, those of us who use antidepressant drugs, to put on 5 to 10 kilos is very, very common. And I have patients who put on 20 or 30 kilograms. And then if you're using some of the atypical antipsychotics for depression, which a lot of psychiatrists are using now, the weight gain is even more significant. Decreased libido, very common complaint. I've seen some studies claiming as high as 9%. I've seen other studies claiming as low as 10%, so who knows what the rate is. But loss of libido, other sexual side effects with difficulties, erectile dysfunction common, somnolence, problems with some of them, arousal with others, upper GI bleeding. So the drugs that you're using, if you're going to say, I'm not treating depression with the epilepsy, I'm going to give someone an antidepressant for that, and I'm going to try a new medicine for epilepsy, so I'm using 2 drugs rather than, say, 1 VNS, you have problems. And then again, this nice study from the BMC Medicine, also a new study from 2018, so I'm trying to keep you up to date with literature when you look at unadjusted and adjusted hazard ratios, and some things that I don't even think about. When I prescribe an antidepressant, okay.
Time is over.
Yeah, sure. I don't think about fractures and upper GI bleeds and motor vehicle accidents, but these things happen, and the risk is there. And then this was a study that you have to take with a grain of salt, because this is patient-reported studies from a company that called people up on antidepressants to see how they felt. But it's interesting, rather than doctors asking them, a company that calls people by phone asking, how do you feel, the incidence of antidepressant side effects was very high. And as you can see, somewhat bothersome, 40%, very bothersome, 19%, a little bothersome, 29%. Most people don't like their drugs. Most don't like them. So to conclude, and then one other thing I'll add, and again, this is even with a drug that I don't think works for it. I'm just going through. But this is a study published that I wasn't going to put in my talk, but I will, in Epilepsy and Behavior this year, showing that lacosamide has beneficial effects on mood. So again, the drugs we treat already have that. So I will conclude with statements saying that many anti-epileptic drugs have antidepressant effect rather than trying another one that's probably not going to be better than what you're presently taking, maybe why not employ a technique that will be good for seizures and for mood and avoid all the side effects of the antidepressant drug, which are not insignificant. And the VNS side effects are modest, and this obviously is done in constellation with discussions with patients, but I think if we want to minimize side effects, maximize beneficial effects, we want to minimize the amount of therapy and hopefully treat our patients more effectively. And again, from a cost point of view, VNS is not really more expensive. VNS may actually be cheaper. It's just a little less reversible. Thank you.